Hello everyone. In this session, we are going to discuss some of the miscellaneous anemia. So far, we have discussed about iron deficiency anemia, megaloblastic anemia. Here, we are going to discuss about miscellaneous anemia. We have something what we call it as dimorphic anemia. What is this dimorphic anemia? That is multiple deficiency anemia. That means this anemia occurs because of vitamin B12, folic acid and iron deficiency. So, what are the features of iron deficiency anemia? Microcytic hypochromic anemia. What are the features of vitamin B12 or folic acid deficiency? Yes, it is macrocytes, okay, with the hypochromia. So, remember, iron deficiency along with vitamin B12 and folic acid deficiency, we will get dimorphic anemia of macrocytes and microcytic hypochromic red cell is characterized. That means we will get both macrocytes as well as microcytes. Fine. And hypochromic. Fine. Yes. In bone marrow, megaloblastic changes may be masked in the erythroblast because we are having iron deficiency as well as folic acid deficiency, so that megaloblastoid changes won't be that much present. Fine. Yes. In the peripheral blood, hypersegmented neutrophils will be present, which indicates that vitamin B12 or folic acid deficiency. Fine. Yes. So, in bone marrow, the characteristic finding is both megaloblast as well as micronormoblast. You know, micronormoblast is a feature of iron deficiency anemia. Megaloblast is a feature of folic acid deficiency. Yes. So macrocytosis may be also be masked, but even hypersegmented neutrophils will be present if that provides the clue that it is due to deficiency of folic acid or vitamin B12. Yes. See, as you can see in this picture, there is a dual population. Am I right? There is a dual population. The what is the cell? What I am highlighting now, it is a microcytic hypochromic anemia, a microcytic hypochromic RBC, and what I have highlighted just this is nothing else but what we call it as a macrocytic hypochromic. So we will have a dimorphic blood picture. Fine. Yes. And here again we can see something what we call it as ovalocyte. See, ovalocyte, we can see hypochromic, increased central pallor. Yes. So we will have here also we will have what? Dimorphic. Here also we will have dimorphic red cells. Fine. Coming into the bone marrow aspirate. See the bone marrow aspirate, I am going to draw with the violet color. These are the micronormoblast and these are the megaloblast. Fine. These are the megaloblast. Fine. Yes. Fine. And what you are seeing here, is nothing else but what you are seeing here. It's nothing else but what is it? It's a giant metamyelocyte. Yes. What is the characteristic shape of the nuclei? It is reniform or kidney-shaped nucleus. Fine. Yes. Because of the iron deficiency, the megaloblastosis will be usually masked. Fine. Yes. Okay. Once this is done, remember we have something what we call it as pernicious anemia. What is that? Pernicious anemia. What is this pernicious anemia? Because of a deficiency of intrinsic factor, there will be impaired absorption of vitamin B12 and eventually we will get megaloblastic anemia. What is the etiopathogenesis? As a result of T cell mediated mucosal injury, there will be formation of antibodies. These antibodies will damage the mucosal cells. Okay, and the parietal cells will be damaged. The parietal cells will be invaded by the mononuclear cell infiltration, leading to atrophic gastritis. Then the parietal cell mass will diminishes. Then achlorohydria, that is the hydrochloric acid secretion will fail. There will be reduced absorption of vitamin B12 to the lack of intrinsic factor, and finally leading to vitamin B12 deficiency and megaloblastic anemia. Fine. This is about what we call it as pernicious anemia. Yes. So here actually I told it is almost like an autoimmune disease. So it may be we have three different classes of antibodies. They may ask this question in your MCQ. One is called as blocking antibodies. Blocking antibodies means block the vitamin B12 intrinsic factor binding. Binding antibody means which react with the intrinsic factor and the complex. Okay, and parietal canalicular antibodies means these are the antibodies which are directed against the parietal cell. So what are the three classes of antibody? Blocking antibody which blocks the vitamin B12 intrinsic factor binding. Binding antibodies which react with the intrinsic factor and the intrinsic factor vitamin B12 complex. And the parietal canalicular antibodies which are the antibodies which are directed against the canalicular system of the parietal cells. Okay. Anemia is insidious in onset. Yes. And what is the classical triad of pernicious anemia? They may ask this question: weakness, sore throat and paresthesia. It is a classical classical triad of presentation. Fine. And there may be premature graying of hair because of vitamin B12 and folic acid deficiency. The patient may have light blue or gray eyes. There may be lemon tint of the skin because of the mild jaundice. Okay, there will be a painful red tongue because of glossitis and atrophy of the papillae. Bilateral symmetrical tingling or numbness and paresthesia, that is classically described as glove and stalking paresthesia. The patient may have ataxia and uncoordinated gait, okay, because of the most commonly involvement of the posterior column pathway. So the pathological finding, it is a type of macrocytic anemia with megaloblastic erythropoiesis. Fine. The tongue is shiny and glazed due to atrophic glossitis. Fine. Yes. And echlorohydria is also seen. That is deficient because the parietal cells are affected. No? So HCl's production is also affected. Then the serum LDH will be increased. Remember, serum LDH will be increased. Yes. And the the main mode of treatment is parenteral vitamin B12 administration. Okay. By injection, you have to give vitamin B12. Fine. Then what are some of the other deficiency anemia? Number one is what we call as copper deficiency anemia. See, copper deficiency anemia is because of dietary copper insufficiency, hyperproteinemia, excessive zinc ingestion, malabsorption syndrome or nephrotic syndrome. And what is the characteristic feature in case of copper deficiency anemia? Remember, it is also a type of dimorphic anemia. Okay, and the erythroblast shows iron deposit. We call it as ring sideroblast. We call it as ring sideroblast. Then we have zinc deficiency anemia. As you all know, zinc is essential for wound healing, sense of taste and smell, as well as zinc plays a very important role in boosting our immune response. So the major cause of zinc deficiency are long-term hemodialysis, intestinal surgery, okay, and even alcoholics and sickle cell disease patients may also develop zinc deficiency. And remember, in zinc overload toxicity also there could be anemia. Okay, not only in deficiency we will be getting anemia, in case of zinc overload or toxicity also we will be getting anemia with the erythroblast and myeloid precursor vacuolization. You can see some cytoplasmic vacuoles in the erythroblast and myeloid precursors. So as far as this session is concerned, the most important thing is MCQs, pure and pure for multiple choice questions. Just remember what is the features of dimorphic anemia. Okay, then the most important, sometimes they may ask pernicious anemia as a short note question. Okay, just go through the pathogenesis, clinical manifestations and the peripheral smear finding. Copper deficiency anemia, what are the two features? One is ring sideroblast, second one is dimorphic anemia. Zinc deficiency as well as toxicity both causes anemia. Remember that, which is associated with out of that zinc toxicity, which is associated mainly with the vacuolization of erythroblast and myeloid precursors. So with this video, I have finished almost everything. Okay, like all dimensions I have covered in the nutritional anemia. We have discussed iron deficiency, megaloblastic differential diagnosis, miscellaneous anemias. Okay, and in the next video we will start with hemolytic anemias. So I hope this session has been useful for all. Thank you.